Um, so I'm going to introduce our first speaker. So we have the pleasure of having Dr. Andrew Novick talking with us today about psychedelics and OCD. Andy is a women's health and psychedelic researcher. He's one of my colleagues, and he's actually a person who, if I have a very complex patient or a complex question, he's always one of the first people I pick his brain. So I'm very honored to have Andy come and talk with us today. Come on up, Andy.
Yeah, it's a pleasure to be here and to be asked to talk today. I get to talk to you today about psychedelics and OCD. About 3 years ago, I started planning a clinical trial of psilocybin for treatment-resistant major depressive disorder. We actually just finished this trial earlier this month. Planning this was a really immersive experience for me, in which I learned a lot about the psychedelic clinical trial design, the pharmacology of these drugs, the laws and regulations surrounding them, and I got the opportunity to actually administer, psilocybin to patients and get to see it really up close work. And I think because of that experience, I've gotten a lot of people who are curious about psychedelics or have questions, both within our department as well as the university. They often come to me, and that's been really, really flattering in a lot of ways, to be kind of considered an expert in this sphere. And simultaneously, it's made me realize, I think it's been a little bit hard for me to kind of accept that role, because I don't fit the mold of a lot of psychedelic experts in the nation and the world. A lot of these individuals often came to the area of psychedelic research starting with their own personal experiences and ingesting these drugs and really kind of coming to believe very strongly in their potential and their efficacy, to the point that they become very large proponents of them and enthusiastic about them. That wasn't necessarily, my route to this. Instead, right, I am a psychiatrist. I'm a researcher. I think my overall goal and interest is in utilizing various interventions, particularly drugs, to see to what extent I can treat and help people heal from really severe mental illnesses. And I think because of this, sometimes I tend to be a little disappointing to people, in that you are not going to get this talk today in which I am going to tell you how amazing these drugs are and how I think they're very much the future, and they totally work for everything under the sun, including obsessive compulsive disorder. What I will tell you is going to be probably a bit more measured and about the very real realities of the data that we have so far, as well as a lot of the challenges and disadvantages that come with these drugs. But at the end, the idea is that if we can be real about that, we have a path forward in how we could potentially improve treatments. So the important thing to know about psychedelics and a lot of the drugs that I talk about, particularly I'm going to be talking about psilocybin, is that it remains what's called a Schedule I controlled substance under the Controlled Substances Act of our country, which means that technically the law doesn't really see it as having any sort of medical use, and really does remain illegal to use under federal law, with the exception of authorized research protocols. And so, it's no matter what kind of the state of Colorado says, the truth is that you're not really going to get a doctor to kind of recommend these things on the record. And I'm actually willing to go a bit further and say that I wouldn't recommend them because I just don't think they've met the threshold so far of having enough evidence and safety and that's just the truth. But with that said, and now that I've probably let a lot of people down, we can go ahead and we can talk about what the promise has, what the research has shown so far, especially in OCD. I think a lot of other aspects of psychedelics, these drugs were really introduced to Western medicine in first, kind of in the 50s or so, and then we started really seeing things pop up in the medical literature in the 60s. So while this was a very experimental time for society as a whole, it was also a time when clinical medicine was showing a lot of interest in these drugs and individuals were writing about them. And so we see things like questionnaires as well as surveys and case studies popping up about all sorts of applications of these drugs, including in an obsessive compulsive disorder. And there's some really interesting, case studies that come up, like as far back as 1966, in which there's descriptions of individuals who were utilizing psilocybin as well as LSD in uncontrolled environments. These individuals happened to have obsessive compulsive disorder, and they reported that their symptoms got better. Subsequent case studies, these case studies would kind of repeat throughout the 70s and 80s and 90s and into the 2000s, early 2000s. Usually the theme would be that there would be an individual who was taking these drugs somewhat on a regular basis, and both their obsessives and compulsions would improve. Often the effect would be short-lived, about a week, 2 weeks. Then their symptoms would return. Sometimes they would redose. Symptoms would get better again. Then sometimes and then it would kind of go away. What they also found too was that despite the fact that the tolerance to what we call psychomimetic effects, meaning the subjective effects of the drug, would often develop with things like LSD and psilocybin, which is a well-known phenomenon. This is why these drugs really don't have, their abuse potential is kind of limited because after you take it a few times within a period of a month or so, it has diminishing effects in terms of how it makes one feel, in terms of how one changes one's consciousness. And so despite the fact that tolerance was developing to some of these subjective effects to it, the efficacy in treating people's obsessions and compulsions didn't seem to decrease, and so this all seemed really promising. In the late 90s, a group at Yale published a case study of multiple individuals, and this then just inspired them to do an actual clinical trial in 2006. This trial is what we call open label. It means that it did not have a placebo group or a control group. Instead, they administered psilocybin at varying doses to around 13 individuals. And they essentially replicated what happened in a lot of these case studies. So people would take the drug, their symptoms got better anywhere in the range of 25 to 50% on the Yale-Brown Obsessive Compulsive Disorder Scale. And then the effects seemed to wane. But then they would redose, and it seemed to get better. And it was really promising, except for one little caveat. They did end up using a really low dose that today would be considered a little bit of a microdose as a control. And that dose seemed to have the same effects as the higher doses, suggesting that possibly we are looking at something of a non-pharmacological effect. It can be called a placebo effect. It might have been influenced by expectations, or perhaps it was a carryover effect from the people's previous dose. But it raised questions to what extent, yep, we're really kind of seeing this, and this is the problem with doing open label studies, that sometimes we don't always know what's going on, and we can't really differentiate what's the effect of the drug versus what's the effect of everything else that's happening. But since then, there really haven't been any published studies of psilocybin or LSD or any other psychedelic in obsessive compulsive disorder. That said, I just looked at what's called clinicaltrials.gov, which is a database of all registered clinical trials that are at least going on. They don't actually need to be going on within the United States, but if they plan on having any kind of use or future in the United States, it needs to be registered with our government. And there are like at least 12 current clinical trials going on in the moment at various stages, utilizing psilocybin for obsessive compulsive disorder. How many of these will, like, some of these won't even get off the ground. Some of these will probably not end up going to completion. A lot of things happen. That said, it is an ongoing area of research. There is, one of the neat things is that one of the individuals who did that clinical trial, the open label one that I was discussing before, he actually kind of entered like a pseudo retirement and came to Denver and started working like at our VA, and I got to know him a little bit, and I talked to him about his work. And he mentioned that he had a theory that he thought that while the efficacy of things like psilocybin and LSD might be due to, it might have a lot to do with like, you know, these non-specific effects and these things that happen a lot after the dose, and that explains why, right, like we see these really impressive effects in things like major depressive disorder that last like up to 6 months after people are dosed. With obsessive compulsive disorder, it had a lot to do with the actual pharmacology of the drug and the fact that these are serotonin agonists in the brain that are hitting serotonin receptors directly, and that might be kind of like what makes them effective. We know that other serotonin agonists are really helpful for obsessive compulsive disorder, notably things like selective serotonin reuptake inhibitors. And we also know that there are some drugs that antagonize the serotonin receptor that we use in psychiatry for other reasons that occasionally will make obsessions and compulsions worse. And he thought that was the reason why you get such this really strong acute effect of the drug, but then it tends to wear off. Unlike if you talk to people who are, whether it's in depression or whether it's just people who have taken these drugs and then feel that they cause induce this very kind of long-term sense of healing, you're just getting different things. It's a different phenomenon. And this isn't uncommon. This happens a lot in which, you know, the drugs that we take, there are these blunt tools that do all sorts of things in the brain and the body, and they target the brain all over. And so the action in one disorder will be different, and the reason why they benefit one disorder will be different than why they benefit another disorder. And that we see this with our psychiatric medications. The reason things like SSRIs are effective in OCD is that it's different, even though it might be overlapping with the reason that they're effective in the depressive disorder. And so that's also different than the reason that they're effective in premenstrual dysphoric disorder. And it happens in other areas of medicine too. And that we have they're all doing the same thing in the body, but they're not different. be a mistake if we didn't move forward and continue to evaluate these drugs. Because I'm sure one of the reasons that inspired a lot of you to come here today is that obsessive compulsive disorder causes a lot of harm to our population and can have a lot of negative influence on people, and is a serious disorder that prevents people from, I think, not only being their best selves, but also contributing to society in a way that is not only productive, but makes the individual feel good. And I think we see wonderful things when we are able to treat people. And so I think with that, I'm gonna actually stop there and open it up for questions if we do have any time left. But I'm happy to talk about anything as it relates to psilocybin or psychedelics, and whether it's what's happening right now with the law and with various clinical trials. It's their efficacy in OCD or lack of efficacy. But
We can probably take one question.
Okay, sure.
You can stick around afterwards.
I can definitely do that. Yes. Yeah, so the question so far, or the comment so far, was that yes, that in the open label trial, what happened was they gave multiple doses to people at various times, and so people might have received what we would consider a high dose of psilocybin, and then at some point during the study, all of the individuals received what would be considered a microdose. That with the majority of people, this would not have any sort of subjective effects. You wouldn't be able to tell, really, if you got anything. Yeah. Yeah. So. Yeah. So the question is whether it would be possible, if ethical, to essentially tell people that they would be getting a placebo, but in reality give them a dose of medication, such that you could test the idea that hey, if people kind of just think that they're getting nothing, right? Then they won't have this placebo effect, and in reality, we're going to give them something. And so, yeah, that's something in the clinical trial world that is called deception, and yes, it is possible. You have to obviously get it ethically approved, and usually you have to tell people up front that we may deceive you in some way. We're not going to tell you how we're going to deceive you, but by entering this clinical trial, you are consenting to the possibility that there may be some sort of deception. Yeah. Mm-hmm.
So, sometimes over a period of time, after they take drugs, they normally have a pause where they have a brief period of increasing symptoms.
Yep.
I think describe how that process happens. Like, on day one, how are they feeling? Not experiencing symptoms, or they experiencing like they're denying or episode of preventing experiencing those things, and then as time goes on, does the pain wear off, or do they actually experience absence of symptoms that come back?
Yeah. So the question is really like, what do we know about what I would call the phenomenology of the experience of what happened to people? What was it like to get a dose of psilocybin and then have your symptoms kind of sort of go away, but then come back, and what was that experience like? And I admit there are these accounts of this in which psychiatrists like try to like write about it and characterize it. But I admit, like, I forgot what it was like. I forgot, but no, that is in the literature, and I agree. It's kind of like a really like kind of like, you know, I think understanding kind of like what is it like, and is this truly kind of the same type of remission that happens in our other, you know, in there with our other treatments or not? Yeah.
All right.
Yeah.
And you said you can't stick around.
I can stick around. Yeah.